Hello, everybody. I'm Bertrand Tombal. I'm a urologist from Brussels, Belgium, and I work at Clinique Universitaire Saint-Luc in Brussels. So the lecture I gave is just about the so-called non-metastatic castration-resistant prostate cancer patient, meaning patients that are usually coming from high-risk localized disease who had radiotherapy or prostatectomy, then receive ADT and have a rise in PSA uh, while they have a low testosterone, and on standard examination, bone scan, CT scan, there is no metastasis to be seen. So I speak about how we should classify these patients in two groups, the low risk and the high risk. The high risk being those with a rapid PSA doubling time of less than 10 months. And but the fact that for these patients we have no three large randomized control trial with enzalutamide, apalutamide, and darolutamide that confirm a huge benefit in metastasis-free survival and a significant benefit in overall survival, so that these treatments have become the standard of care for these patients. And then I address also the potential role of PSMA PET imaging and metastatic targeted therapy, which I believe should be limited to the low-risk patient. At this point in time, in the clinic, we don't do systematically PSMA PET CT if the patient has a high risk, meaning if the PSA doubling time is very short, we limit ourselves to standard CT and bone scan, and we decide based on this. Because if the patient is not metastatic, we're going to start one of the three, APA, ENZA, or darolutamide. If the patient is metastatic, we're going to start abiraterone or enzalutamide. So I believe that the benefit of metastatic targeted therapy in that setting is still to be demonstrated. And to me, this is just delaying the treatment to do another test. In contrast, I recommend PET PSMA to all the patients with a low risk disease, so those with a PSA doubling time more than 10 months, because there I believe that if the patient has oligometastatic disease, there is space to discuss ablative therapy, including surgery sometime for these patients. So that's why the classification low risk, high risk is important. And in the high risk, I don't recommend that exam. So I believe that unfortunately, in the castration-resistant prostate cancer patient, there is very, very limited role for metastatic targeted therapy, and this should be limited to clinical trial. We don't have real phase 3 trial either at other stage of the disease, but if you take, for instance, the patient with a rising PSA after radical prostatectomy or radiotherapy, we have good phase 2 trial and very encouraging results, so that when the patient is hormone naive, I believe that this is a very robust option. Unfortunately, when the patient is castration resistant, and especially if it's got a rapid PSA progression, we simply have no good data at all. So I wouldn't recommend it outside clinical trial. We should not break the equipoise on these patients. We still have to demonstrate it has some benefit. So I think that once again, the future has to be seen differently for the low risk and the high risk. In the low risk, the future will be to look at metastatic targeted therapy, eventually combined with a little bit of hormone therapy, modern hormone therapy. But I think that in these patients, there is no hurry. We have shown that their rate of progression is quite slow. I think in the high risk, we put these patients for long duration of treatment, 2, 3, 4 years, with these drugs who have some toxicity and who can cost a lot of money. So I think the future will be to look at combining metastatic targeted therapy based on new imaging with the idea to kind of shorten the duration of the treatment. And I think that the future will be to go on tailoring the treatment, not only on the PSMA doubling time, but on the combination of PSMA doubling time of new imaging technology, so that we will avoid this kind of black or white situation where you give nothing to the low risk and you treat the high risk for very long, prolonged period of time. So I think that the future will be more precision medicine around new imaging technologies.